Familiar faces here, so you know, I'm glad to be able to give a talk for about 30 minutes. So I'll just divide it up into talking a little bit about what is motor neurone disease. Then I think Sarah's really wanting me to focus on the pathways that are out there, and then if we've got time, we'll talk about research. So what is motor neurone disease? And it's the terminology, I think, that sometimes gets a bit confusing. Motor neurone disease has been recognised since about 1865. It was a French neurologist, Charcot. So for many years, and in France, it's called Charcot's disease. Motor neurone is a broad term. It covers a number of other rare diseases, but basically the idea is that there is a motor neurone in the brain called the gamma motor neurone, and that travels down from the motor cortex down through the spinal cord and meets a cell called the anterior horn cell, which then is the motor nerve that travels out to the muscles and supplies the muscles. And so each anterior horn cell has a connection with a number of muscles, and for most people in their arms, maybe 100, 150 motor units are present, and a few less in the legs. And the number of connections of those motor neurons with different muscle fibres is one theory about why some muscles are relatively preserved. So the use of eye movements and bowel control is relatively preserved throughout motor neurone disease. Another muscle which is obviously very important is the heart muscle, and that's controlled by other means, and what's called the autonomic nervous system, so sympathetic, parasympathetic nerves, and so that's not affected. So it's only what comes from the motor cortex that seems to be part of this disease. But when that French neurologist Charcot first recognised the disease, he recognised it in the anterior horn cells. So sometimes you'll see those terms, anterior horn cell disease. But just to make it confusing, the Americans then brought in the term ALS, and through the Ice Bucket Challenge, that term has been very much the predominant term. And in fact, the old term that the Americans used, called Lou Gehrig's disease, has largely disappeared. But one way to think of it is ALS means involvement of the upper nerves in through the brain, motor cortex and spinal cord. They're the upper motor neurons, and then the lower motor neurons are the anterior horn cell and the motor nerve and the muscle fibres. And so ALS is the combination of both. Now, if you've only got involvement of the upper motor neurons, that's called PLS, and if you've only got involvement of the lower motor neurons, other terms like PMA or flail limb get used. And all of them are motor neurone disease. So that's quite confusing, obviously, for the people in the audience, but it does mean that you get these very clear little patterns. And the other thing about motor neurone disease is it starts in one place, and for a reasonable period of time, and hopefully for as long a period of time, it often stays relatively restricted to that place, and that can be even years. And the spread is relatively even, so it's 30%, 33% in the bulbar involvement, 33% in the upper limb, and 33% in the legs. And very rarely does it start in the breathing muscle, but sometimes does. And then it runs really patterns where it's very rare under the age of 40. It certainly does occur under the age of 40. I think 25 has been the lowest we've been involved with. But if people are going to get motor neurone disease, they largely get it by the age of 75 and rarely after the age of 80. So it's got these unusual patterns. It's got an unusual pattern that it's more common in men. About 1.2 is to 1 if you look at motor neurone disease. But for a couple of reasons, in the clinic, it's probably even higher than that, the male to female ratio. And you see these ratios, see these patterns of older women with bulbar involvement and middle-aged men with arm involvement, and then involvement of the legs is relatively constant. And the patterns are what sort of gives some a way to be a little more confident on the diagnosis. And you know, the making of the diagnosis is extremely frustrating for patients. I think everyone here is going to have a journey of where it's been difficult. With a passionate researcher over in WA, Sama Aoun, A-O-U-N, we published 3 papers, one based on the perspectives of the person getting the diagnosis, family and caregivers, and also from the neurologists. And you know, I think neurologists don't give the diagnosis in a easy, easy way. I don't think enough time is given, enough follow-ups given. But sometimes it's also quite difficult to be definite about the diagnosis. So I'm sure everyone here will have stories of frustration where people have said, well, you know, what really is it? And the only comfort is that if people have struggled to give the diagnosis, that's actually a good thing. And if they look at survival, it's very clear that the best chance of survival is if the neurologist is not sure of the diagnosis. So typically patients have had symptoms for, and it varies, bulbar disease is probably 12 months, upper limb is probably similar. Most people have had symptoms for about 12 months before the diagnosis, but walking can be quite a bit longer, so 18 months might be the average. None of the patterns are absolute, and I guess that's what's been so frustrating for research. The spread does run a fairly typical pattern of spread of disease, so that gives us a little bit more confidence in what we're dealing with is motor neuron disease. But it's important to try to rule out other conditions, particularly some immune conditions like multifocal motor neuropathy. Men can have a disease called Kennedy's disease that looks similar, and there's other rarer types of diseases that are important to exclude or to try to treat. So, you know, the actual diagnosis of motor neuron disease is it's frustrating for patients, and it's challenging. And I guess it's come about that most neurologists will probably refer to someone with a bit more expertise. Here in Queensland, it's probably Pam McComb or myself who would see most people from that motor neuron disease angle. So the things about motor neuron disease that are, it's often people who, there's a perception, and it's very hard to do proper studies, that people are actually a little healthier and a little more active than people with other diseases. One of the researchers who is, young and passionate and clearly incredibly smart in the UK, Amar Al-Shalabi. So he's saying that diabetes is actually a negative risk factor for developing motor neuron disease. He came up with this idea of a 6-step hypothesis and then added diabetes at the end. But the idea that it takes 6 hits for a person to develop motor neuron disease. Sometimes if those hits have a genetic basis, that might get you a little bit up the scale. Maybe even 2 can be accounted for by genetics. But it's clear that even in those people who have genetic forms of motor neuron disease, that there are other factors. There must be factors related to age. The fact that we just don't see motor neuron disease very commonly under that age of 40. There must be something in that factor as well. So his 6-step hypothesis has very much been one of the breakthroughs that occurred in the last decade. In general, no environmental factors have clearly been shown to and proven, because it's really hard to do research and prove research. it's easy to do studies and it's easy to show an association, but many of those studies just don't hold up. People might be aware of, HRT and breast cancer. It took a really large study to show that there was an association. So smaller studies can give you a false impression. So there's a lot of interest in activity, and the Italian soccer players, Gulf War veterans. But when we put a map of what patients we see, it's almost a perfect map of where people live in Queensland. Blue-green algae is obviously an area that's of a lot of interest, and a lot of that came from that area of Guam where there were cyanotoxins, and they had a higher incidence of a disease that it had motor neuron disease, Parkinson's, and dementia, and it seems to have got less with time. But for most people, blue-green algae is hard to think as a definite answer, but there is still a lot of research happening in that, both in the US and at Macquarie in Sydney. The genetics of motor neuron disease is an area of active research, and there are gene-based trials that are occurring, so some of those have been in the media in the last month or so. And look, they are evolving. So one of the breakthroughs for motor neuron disease in the early 90s was discovering a gene called the SOD1 gene. So 90% of people don't have that gene, don't have any gene. 10% will have a gene that passes down through family members, but 90% don't. So that SOD1 then was only 20% of that small proportion. But about 10 years ago now, a bigger breakthrough came with the identification of a gene called the C9orf72 gene, and that linked in also with some of the cognitive aspects that occur. Practically, we don't see a lot of cognitive involvement, and it relatively slowly progresses compared to motor weakness, but that is an area that's led us to really chase down a novel area of research is into the cognitive aspects. So the C9orf72 gene was a big breakthrough, and more recently they've found a lot of other rarer genes. And so it's got to be that if people do have a family history, there's more than a 50-50 chance that one of those genes will be recognised. Now, why is that important? Because most people don't really want to know that. Well, there are those gene-based clinical trials now. So for both the SOD1 gene and that C9orf72 gene, there are clinical trials happening. And I guess some of the breakthroughs that are going to occur in the next couple of years are going to come from a better knowledge about that C9orf72 gene. And there are people out there that are obviously not very happy that they have those genes, but I guess we're keeping quite a large database, and we've been trying to apply to bigger funding agents in Europe and the US to try to do a proper project to really study what's really going on to cause those people to get motor neuron disease. So the involvement of motor neuron disease then is those patterns that make someone suspect motor neuron disease, and then they see their GP and eventually are referred for investigation. So most people will have a story that they've had an MRI of their brain and spinal cord. They'll have had some blood tests, but the test that probably gives some confirmation about the diagnosis is called an EMG, where a needle is placed in muscles. And sometimes, even if there's uncertainty, that might be repeated down the track. And so then people, the diagnosis, and as I said, we can certainly do better about trying to communicate that, because it's clear that there's that we're not doing it as well as we could. But then once a person has reached that diagnosis, then there is the intersection between hospital-based clinics and the community. And I guess pre-2005, 2010, there wasn't anything hospital-based, and we set up our clinic on Friday lunchtime because that was a place that enough people who were interested in motor neuron disease could all meet to be involved in the clinic. But gradually over time it's evolved that there's a network that exists in Queensland, and it's actually a network that works in terms of everyone getting on very well in terms of providing care from a hospital. And as I said, that's quite separate to the community, and I think as people's motor neuron disease evolves, then they find it harder to get to the hospital. They don't like hospitals, quite rightly, with car parking, with other issues. So community-based care rises. But the hospital-based care is important. So it's important for symptom management. So, people who have a bulbar onset disease, the saliva management, the speech and swallow becomes important. And for involvement of the limbs, things such as spasticity, management of pain can also be quite important, and also recognition of breathing involvement and managing that. So the symptom management was probably what led us to really drive involvement of our clinics. So the first one that was established was at Royal Brisbane and Women's Hospital, where I am, and I guess it was based on needs that how it has evolved. So there we have myself and Pam McComb as neurologists. A nurse and a nurse coordinator is very, very important. A nurse coordinator being able to link with patients and also to be able to link with the associations. And the people who've been really passionate have been the speech pathologists and dietitians. And then research has also been able to tap in through that clinic. So over time we became aware that the involvement of respiratory physicians was important, and also the involvement of palliative care specialists. Palliative care specialists see our patients right from the word go in our clinic and are very helpful on that symptom management and trying to develop pathways for those patients from a point of view of making the journey easier. So if people live a little further north than the centre of Brisbane, Prince Charles was the next place that we were involved with a clinic, and that has a very similar structure to the Royal Brisbane and Women's Hospital. In about 2012 we started telehealth there, and so people who largely live outside Brisbane, that's how we would connect with them through the Prince Charles. At the same time, it became clear that the provision of the respiratory services, there was an application, again, more than a decade ago, that towards the state government actually funding the provision of non-invasive ventilation, so the use of BiPAP, and so that was a good step forward. And at PA Hospital, they very much led a respiratory-led clinic. So if you live south of the river, the PA Hospital clinic's been highly effective. So originally set up by Craig Hewkins. More recently there's been a change in the respiratory physicians. But as a nice example of connection, the neurologist who is involved in our research, Po Yang, we've been able to encourage PA to have him do their M&D clinics. So that's actually something that's only happened in the last year. So, and the nature of Queensland Health is they can make it very complex from the viewpoint of different boards. So Metro South Board is a bit different from Metro North Board. So Metro South Board are able to employ a nurse who can also connect with the community, and Lois has been in that job and very passionate for a very long period of time. But say at Royal Brisbane, our nurse Lily, who's very passionate, she will only be hospital based. So in that case, linking with the associations is one of Lily's key roles. So then in the last few years, we've been very supportive of Gold Coast and Sunshine Coast also setting up their own clinics. So again, they're based on the idea that you have neurologists, respiratory physicians, nurses and interested allied health. And so Anthony Winkle at the Sunshine Coast is involved, and it had been Aman Sabat, and I think there's a couple of people who'd been our fellows are now involved through the Gold Coast Hospital. And it's good to have continuity of care. So down the Gold Coast, Jenny Stoffmeal has been in a nurse practitioner role and been very supportive of people from the hospital base. So, you know, you've got to think of hospital-based and community-based care, and they do overlap and they do work well together. I'll just touch a little bit on research. So in Queensland, we link in with the rest of Australia in terms of databases. So there are two databases. The one that had been existing and been very much set up by UQ was called the SALSA database, but now there's been federal government funding for a database called MindAus, so MND Aus, AUS. So we were very much trying to encourage everyone to be in that database. It gives us a clear idea of patterns, demographics, and the aim is to try to have a national-based research involved. So nationally, it has evolved that there are particular clinics in each of the capital cities, and particular people who have very much become passionate about motor neuron disease. So Merrily Needham in WA, David Schultz in South Australia, and in Victoria, Sue Mathers and Paul Talman, and then in New South Wales, Steve Vukic and Matthew Kiernan have done it very much from the public hospital setting, and Dominic Rowe at Macquarie is also involved. And that's led people to be able to be involved in clinical trials right across Australia. And it's also allowed this database called the MindAus to work. And governments don't fund motor neuron disease very often, but they have on the basis that they can see a network of people working well together. So in research, one of the frustrating things about this disease is that there's no easy animal model for the disease. There's no other organs involved. Largely right across the board, people will not have anything else involved besides their motor weakness. So the lack of biomarkers of what's really going on in motor neuron disease is just one of those challenges. A lot of people over time might have been involved in some of our electrophysiology research to try to better understand those number of motor units. More recently, we've also been collecting blood and as part of a previous project, urine, to look at a marker called neurofilaments. And neurofilaments are just a marker of axons. So in motor neuron disease, the main motor neuron is called an axon. So in anything that causes death of axons, then these neurofilaments get elevated. So trying to come up with biomarkers has been really the challenge. As a measure, the really only two markers that are used in clinical trials are the forced vital capacity, a measure of your lung function, and a questionnaire, a screening questionnaire called the ALS-FRS, and it's a screening of 48 points that people would fill out at various times. With COVID, some of those things have now become home-based, so some of the clinical trials you will actually be doing those measures at home or over the phone. and certainly from our viewpoint, COVID led a couple of clinical trials to come to Australia where they might have been more based in Europe or the US. So with our philosophy at the research through RBWH and UQ, and I should add that we've got a little project with QUT as well, looking at trying to come up with a biomarker of muscle strength that's non-invasive. I think a couple of people here have met Luca, who's he's trying to come up with this measure that that makes it easy for patients to measure. It doesn't involve a lot of movement, but the brains is right behind the scene to try to come up with a measure of a thing called persistent inward currents. But otherwise, it's largely been through Royal Brisbane and UQ, and we've basically had the 4 pillars of the idea of clinical trials, trying to better understand genetics, trying to better understand cognitive, and the area that's really going well, and you'll probably hear from Shu and Derek, has been trying to understand metabolism and how that gives us a new insight into motor neurone disease. So just a couple of quick words on clinical trials, and we've got the hope that everyone could be involved in a clinical trial. So you can think of clinical trials on a number of different bases. Phase 1 clinical trials are trials where not a lot's known about the drug. They're trying to prove that the drug is safe in the motor neuron disease population, and they're also trying to understand the pharmacokinetics, how that drug actually works. So in most phase 1 studies, everyone gets the drug. And at the moment, there's been also a couple where lumbar punctures are performed. And then the nature of motor neuron disease and the fact that it's relatively rare, most phase 2 and phase 3 studies, they all little overlap. But phase 2 and phase 3 will usually involve some people getting a drug and some people not, which is called placebo controlled. Most motor neuron disease studies are 2 or 3 people will get the active drug to 1 person on the placebo. Most trials run over a period of 6 months, and then everyone is usually on the drug. And over the last 7-8 years, would be in double figures now with trials, of which about half of them are ongoing. The Ice Bucket Challenge was probably the change to really give a boost to clinical trials happening. A lot of that funding, seems a long time ago, but it went into the basic science research to get the ideas that then get translated into clinical trials. Some clinical trials are investigator-driven, and Shu and Derek have been real leaders in one of the trials that's coming from UQ. But some are also driven by biotech companies, and most of the time large pharmaceutical companies are just not in this area. So large pharmaceutical companies would fund 20-30 million, but the smaller biotech companies fund a smaller amount. And so that's obviously one of the limitations for doing, you want to do as big a study as quickly as you can, as best you can. There's always a lot of talk about other therapies for motor neuron disease, and we've always had the philosophy that, if it doesn't cost too much, doesn't take you away from your loved ones and doesn't cause side effects, well, there's no real reason not to. But the honest answer is, if any of these drugs did show a benefit, then I'm pretty sure some of these biotech companies would be jumping in there very quickly. So most of them have not stood the test of time to be persistent. Sometimes we actually see some drugs pushed for a little while and they'll disappear and then they'll come back. And an example of that might be naltrexone, that when I first became interested in motor neuron disease, that was the flavour of the month, and then it made a comeback a few years ago. There was a site called ALS Untangled. It's still there, but I think the number of therapies is probably they need to keep up to date, because often when someone comes into the clinic, and very much welcome people to ask about it or email, because I go and look it up, and in the last week or last month there's been a couple of new ones proposed. So most of the ones that have got into the market have been on the basis of one or two studies that have only shown a possible benefit. So to take it then to the next level, to say, well, a bigger study, have we got your dose right? It just hasn't quite happened for those other products as yet. And so a nice example would be Davarone or Amylyx, which is in Australia, both of those drugs have not really been pushed, mainly because there hasn't been any company behind it to lobby the federal government to allow an import licence. But they're just a little short of showing a clear benefit. The only drug that is freely available is the drug Riluzole. It has both a tablet form and a liquid form, and Riluzole was part of two large studies in the New England Journal and Lancet back in the mid-90s, and it did show a modest benefit at slowing a disease progression, particularly in those with bulbar onset disease. So the pattern of more rapidly progressive patients would start in the bulbar region is one of those phenotypes that we see, and that was the group that there was a benefit from the Riluzole. The benefit, was relatively modest in terms of number of months, but I think just that disease variability washes down any possible benefit. About 10 years ago, we did a totally uncontrolled study and said, well, the survival of people on Riluzole compared to those who didn't take Riluzole, and it was about 12 months difference. But that is a totally biased study, because the people who were on it were more motivated, they were perhaps more likely to think about involvement of breathing muscles. And so, clearly the two interventions that happen in motor neuron disease are the consideration of that breathing and also the consideration of feeding. For a long time, people didn't consider that feeding was a survival advantage and more of a quality of life advantage, but I think that's changed a little. Whereas the breathing is a very clear survival advantage, and in the study that was there was more than it was a 12-month benefit on those, and again that's a watered down effect. So the use of non-invasive ventilation is very much an intervention that makes the most difference in motor neuron disease. But for people, it's really only something they'd consider on a symptom basis. So those are symptoms of shortness of breath, lying flat, waking up at night short of breath, morning headaches would make a difference. So I might stop there and see if anyone wants to ask questions. I've only left 5 minutes, but hope that's okay. Any burning questions?
Blue-green algae the same as spirulina?
Same as?
Spirulina.
I haven't heard that that term, spirulina.
Spirulina, blue-green algae.
I don't know, so
It's different.
I'm not sure. So squalene, but that's a different term again. That was a drug designed to have an effect against blue-green algae and motor neuron disease, but that's not the word you're using.
It's a protein-based algae. It's still
Yeah.
algae, but
Yeah.
health fanatics take it, so I was wondering.
No, so I'm not sure.
How does one find out what type of MND you have?
So again, seeing a neurologist or seeing one of the MND clinics would be the key.
Yeah,
Yeah, quick one, Rob. You just talked at the end there about breathing, when you're laying on your back, reduction in breathing, and that's where the Resiol may help.
No, so that's when the use of that non-invasive ventilation. So
is that a classic symptom? Upright's okay for breathing, laying on your back, shortage of breathing?
So there can be other things to consider, but that would be relevant.
Because I know it's not about me, but since COVID, laying on my back, breathing's changed. I had COVID earlier this year. But I'm trying to wonder out if it's the MND symptoms or it's just a byproduct of having COVID. Yeah, interesting. Anyway, we'll
should
talk about
chat
that next time. Yeah, thanks.
How do you get onto the UQ MND Oz website database?
So the MindOz or the SALSA database. So I don't know if Derek may touch on that when he comes up to talk, but our research nurses would be very much the people to contact. It is driven by UQ. Yeah. Yeah, so Derek?
I have the contact details on my last slide.
Okay.
I'm seeing Dr. Sabat in the Gold Coast, just new, haven't started any trials. Do they combine Gold Coast and Brisbane, or they solely Gold Coast? Or?
So there are a couple of studies that the Gold Coast is a primary site for that study. So I think the Lighthouse study might be one. So we often have a session where we talk to patients, often via Zoom if they come from the Gold Coast, and explain a range of different studies. But some of them, Gold Coast is actually the primary site.
And also be some done up here, apart from that?
Yeah, that's right. So probably at the moment there's four active studies recruiting. Through Wesley Hospital there's also some of the more phase 1 studies and also some of the more gene-based studies.